a termination of pregnancy can be worse than having the baby with the few anomalies or the severe or even the baby die. For example, for me, a little anomaly is not an indication at all to terminate the pregnancy because it's little anyway. And I go with Badr, who is very positive, and I tend to be very positive because I feel it's the better road for the patients. But I can tell you, as Badr said, the fear of a baby with an anomaly exists in Qatar, and there are couples that will go abroad and have the termination after being warned that it's not the best solution. It's not the best solution. It's not because we know how to do it that it should be done or we should counsel in that direction. For any anomaly,
If you allow me to comment, at HMC, which is the main hospital, the rules are very clear. Or to affect the existing children. Look at how people are careful in making the comment. And yet when we come to discuss this, we will put their personal views on this without thinking about it. They have coding problems, but the Sharia people, they have done their job. Now, there is something else completely different from what Karim and others are talking about. Here we have a woman who got briefly forced cesarean delivery, 4, and she wants to have 7 children. We're going to give her a cesarean section for an encephalic baby. Is that fair? Is that fair? That's what's happening every day. After the patient, some patient will choose to bring up a Down syndrome baby, and they have complete right to do this. And
with Sharia law, not allowed to terminate Down syndrome.
This is not true for what?
Which is compatible with life, is allowed if trisomy or anencephaly, trisomy 18, 13, which is lethal disease.
Because even with an encephaly, when I was in Dorchester, I had a Jewish patient until baby died in my arm. We carried with the pregnancy, she delivered a normal baby, there's nothing called must. Now I come back to Down syndrome baby, and I come up with the fatwa again. What about the existing children? They're all 2, 3, 5, 7, and 8. By the time she has Down syndrome baby, these 7 children are
2 days means this point which you raised regarding the risk to the family is important. But some people in Sharia also, they said 122 days. In that time you have a larger space for termination, but not all the Sharia people. Actually, Down syndrome, I don't know if you have new information. Down syndrome is not indication for termination.
What I'm saying was the fatwa from Saudi Arabia was saying up to 19 weeks. Up weeks for abnormal baby.
And I don't think ever you can do it. Ever. No, even generally, my opinion, because I'm very life positive, pro-life. 42 days, I think it's just a matter of convenience. Just take a syringe and you just suck it on.
People say you can terminate the pregnancy in 42 days. You can go up to 19 weeks if there is abnormal baby. Down syndrome is a debatable condition. But the fatwa.
The husband should agree, yes. So three conditions for termination if before 42 days.
I think 42 days is very, very easy. I mean, they do it with a menstrual syringe,
Yeah.
But after that is, I think, just anybody who wants to, but 120 days, prior to 120 days is, I mean,
more logical.
Our religion, yes. That is the only time that we can terminate.
You say now that it is legal to terminate pregnancy at 6 weeks for whoever wants. And this cannot be, I think, because if like this, we can send any patient who is unplanned pregnancy to hospital to terminate. Nobody will terminate this pregnancy because everybody starts small. Unless there is medical indication, we cannot terminate pregnancy. This is illegal.
We're not doing enough as doctors to put our point of view, but campaigning for this. We're not doing enough to ask for this. That is the curve. Remember that the liquid volume is the chronic variable, which means that if there's a decreased liquid volume, it means that the IUGR is going on for some time. It's not an acute event, it's a chronic variable. So remember, what I told you about the lichen being diminished towards the end of the pregnancy. That is normal. Now, a small baby, IUDR baby, should have a reduced lichen. It does not go together to have a small baby and normal lichen or polyhydramnios. If there is a small baby and there is polyhydramnios, there is not IUDR due to placenta insufficiency. There is something else going on. And there are the examples, either trisomy or infection. So if you have a patient who came to refer to you because of IUDR and you find the lichen is normal or even slightly excessive, then this is not a placental problem. This is something else. And most probably this is trisomy or infection. Most probably trisomy because infection will have other signs. And in that case, karyotyping is important. And that's why one of the most important assessment tool of a small baby is karyotyping. This is one of my patients, I remember her, long time ago, Sudanese patient, 74 years of age. He went to FMU at 29 weeks, and the baby was small. There is no story here. The story was that the lichen was normal. I wasn't convinced that it's an IUDR, so we did cholecenthesis, and I got this result. I didn't know what it is until I got the result. A very rare syndrome. So the message is, a small baby normally will have a reduced lichen. Now, a small baby will change the fluid on the baby, and then there will be adaptation. If there is a problem with the placental flow, if there is a problem with food for the baby will adapt. That's what we call fetal adaptation. If the baby does not adapt, you and me have no chance to follow the baby. We have the chance to follow the baby because the baby senses that there is a problem and change the routine. And that's what's happening in what we call a fetal adaptation. Baby is very clever. It will change the style of life when there is insufficiency. And that is an example. This is my friend that was straight from India. This is how the baby distribute, or the fetus distribute blood when there is no problem. When there is wafara. That's how it do. Upper body, lower body, lung. Because baby is having a lot of food. There is building muscles. But if there is problem with the placenta, look what happened. That's what happens. Give blood only to the adrenal, to the heart, to the brain, and forget about the rest. Survival. They want to survive. So the only way to survive is to do this. When the baby does these changes, you and me have got the chance to pick up these changes and then can follow up this baby. If the baby does not do adaptation, we have no chance. So the fetus responds to hypoxemia by hemodynamic changes. These changes can be early adaptation or late adaptation. Early, it means that at the early stage of the disease, and late at the late stage of the disease. Early stages can be done by general obstetrician gynecologist. Late adaptation, it can be followed up at fetal medicine centers. And I will show you in a minute. So what happened is, there is placental disease, there is no nutrition, then the blood flow will be rearranged. Shunting blood to vital organs, brain, adrenal, heart. Forget liver, skin, kidney, and gut. They are not organ necessary for survival. And that's why baby change. Become small AC, like it will reduce, there is no flow to the kidneys, and so on and so forth. And that's why you and me can follow this baby. Can follow the baby by what? By looking at the weight of the baby, and the blood flow, and the lichen volume. And the changes can happen in 3 vessels, mainly the umbilical artery, the MCA, and as we're going to talk about ductus ignotus in a minute. And also, I like this slide. Sorry, I forget to tell you go back to sleep. Now you can go back to sleep. The adaptation change into 2 centers. There is the arterial side and the venous side. The arterial side of circulation is the umbilical artery and the MCA. The venous side is ductus venosus and the umbilical vein. So what's happening? What about the umbilical artery? The umbilical artery is the artery which you and me examine every day 40 times, or sometimes 50 times. It's a very important and vital artery for the life of the fetus. And his measurement is very simple. And that's how it looks like in real life. I want to remind you that you can make the umbilical artery blood flow in two ways. Either in a free loop of cord, or you can make it around the bladder. And I encourage everybody in this room to train yourself on how to do it around the bladder. Because if you do it around the bladder, it means that you have good look at the bladder, which is a good sign of health. And also there is a higher resistance here. So if the flow is normal here, it means normal everywhere. And the third important point, if you have twins babies, if you have twins, the best way to do it is by doing the umbilical artery around the bladder. Because if you're doing a free cord, you may be confused with twin A and twin B. And one of the worst things in medicine is you do something for the first time. So if you do it for the first time, you will not be so competent. So I encourage you every now and then, put your curved dog around the bladder and do the measurement around the bladder. The umbilical artery blood flow look like this: systole, diastole, systole, diastole, and so on and so forth. You can use it without color, and you can put color dog. You don't need color dog, but if you have it, you can use it. And then you can measure it. You measure the end diastolic and then systolic, and you get a measurement. What we don't do in this part of the world is this. I don't know why we have this type of chart. I've rarely seen people using the chart. Although the chart probably in manual biology is the most important thing. Because if I put a measurement for the umbilical artery blood today, after 2 weeks I can see the difference. But if I don't do it, I will never have a difference. The same thing about the weight. So please, if there is a chance to use the chart, please do it. So you go to end diastole, end systole, and then you get the measurement. This is the normal umbilical artery blood flow. This is the most important vessels in the penis. This is the most important vessel in the penis. So what happens to this artery? It can be normal like this one. If it change, it becomes high resistant first, and then become absent diastolic flow. Like here, you have systole, absent, systole, absent, systole, absent. Now we call absent diastolic flow. This one, and this one, and you can see this one here, absent diastolic flow. There is no flow in diastole. It means that the baby cannot get blood flow through the cardiac cycle. And here, the same thing. And here, it becomes worse because it goes the other side. That's what we call reverse flow. So the umbilical artery, fetal umbilical artery is the most important vessel to integrate during intrauterine life. And we have to remember this slide. You have no other way. This is the normal, this is absent diastolic flow, this is the reverse flow. You have no other way not to know this slide. By the time you get to here, you have lost about 70% of your placenta. 70% only, because 30% is still there. Now, this is important because it means that if the baby is more than 74 weeks, get the baby out. But the umbilical artery is very important. When the umbilical artery becomes absent diastolic flow, don't do it again. It's finished. It will not tell you anything more. The minute you get more umbilical artery blood flow in the absent diastolic flow or reverse flow, it means that the umbilical artery blood flow has finished its job completely. Now go and look somewhere else or get the baby out. So what is somewhere else? Somewhere else is the middle cerebral artery. You go to the baby's brain and you look at the blood flow in the brain, what you call middle cerebral artery blood flow, or MCA. And that is very simple. You just get a BBD picture, you put your color box, and you try to look for the middle cerebral artery, and as usual, there is a chart as well for it. And the idea is, even if the umbilical artery blood flow is absent or reversed, and the MCA is normal, this baby I still have got the chance to stay in utero. Why I'm making a fuss about this? I'm making a fuss about this because I'm going to show you now a slide saying that for every single week the fetus stays in utero, you reduce morbidity and mortality by a factor of 30%. 30. And this is how we do it. It's very simple. You can train one day on this. You can see the head, you can see the diameter, and you put your current Doppler, you see the circle of Willis, and yes, you relaxed, baby is not moving, you're not moving, you see the muscle, you can magnify it, and you put your cursor, and you get the flow. You can see it in a minute. So that is the flow. That is the MCA. If the MCA is normal, that is a very reassuring sign. It means that I can sit on this bed. I can wait. And again, I remind you about my obsession with chart. Please use the chart. This is a slide I told you about, and I'm going to read for a few seconds. And I'm going to read it. After 24 hours of gestation, the prenatal mortality decreased by a factor of 37% for each week the fetus remained in utero. And I am a strong believer, and I am, that the most important function of fetal maternity, especially in any hospital, the development of the IUGR. The fancy CBS and intra-blood transfusion and clever things done by Ozek and Karim, intra-blood transfusion and laser, is done for only very small minority. But this is a big problem. This is 10% of your population. And I still insisting that probably one of the best service which the FMU does to any unit, any hospital, is the management of IUGR. They will never realize this with what you are doing. It is underrated, underloved, but that is the most important contribution. We talked about the arterial distribution. Now we're going to talk about venous distribution. When we get to venous distribution, it becomes very, very hard. It becomes more of a problem. It means this baby is the wrong way.
It's not for local law in Qatar. In Qatar, you are not allowed to terminate at all. Otherwise, they will close your clinic and they will terminate you immediately. No, what I mean, really, this is not to give the chance for anybody for termination. We are here in scientific discussion. It is not, we are not discussing the law of Qatar. Law of Qatar is...
I think we are, as a people working in this city, we have the obligation for the society, and that's part of it. So thank you very much for coming. Somebody may ask, why do we speak about IUGR, such an old topic, a small baby? There is a very, very clear reason for this. It's a very common problem, and it is the main cause of prenatal mortality. It's number 3 cause of prenatal mortality. But look at the end of the slide, 40% of unexplained stillborn babies are IUGR, which are undiagnosed. So these are enough reasons for me to speak about IUGR. But there is something else which makes me speak about IUGR, the future. I'm going to speak about something called the tranquil study, which I think all of you need to know about it. It is a trial of randomized umbilical artery blood flow in Europe. It is a trial. Outcome of this trial will change completely the way we manage small baby. And as you're going to see this. I will speak about IUGR also because there is now a new test for the fetal lung, which is done by ultrasound. And also, I hope I finish by talking about the future and trying treatment of IUGR. Now, to tackle any problem, it's obvious that you need to define the problem. And that a problem for IUGR. It has been around for a long number of years, but still we disagree on how we define IUGR. What I found, probably most people will agree on, that an IUGR baby is not percentile less or more than the normal weight, but it is a baby which failed to fulfill its own growth potential. A baby which failed to fulfill its own growth potential. That is an IUGR. And for me, this is a very important slide. Simple slide, but very important. When you have a small baby, 70% of these babies are small because they are small, because they are born small, because they are destined to be small. And there is nothing wrong with them. There is 20% who are our problem, which is because the is not functioning very well. That is an IUGR. And there is 10% which you have a problem with. These babies are small because they are not well, because they are sick, either because of infection or because of abnormal chromosome. This is the very important slide. And I think this slide will probably sum up the whole story about IUGR. Now, I talked about the new trial, the travel trial. The travel trial came up with the new definition of IUDR, which is probably going to be used universally. That an IUDR baby is defined as the baby with small stomach and abnormal Doppler, full stop. A fetus with a small AC and abnormal uterine artery Doppler. That is the IUDR baby. So an IUDR baby, as I said, is the baby which failed to fulfill its own gross potential. And we talk about the concept of customized chart, which is a bit old concept. But I like this slide, which I made long time ago. I love it. It's very, many years ago. Look at these women from different parts of the world, Western European, South American, Southeast Asia, and Africa. These are not the same human being. They are different. They are all human beings, but they are different in their size, in their legs. This woman, a baby of 2.5 kilo for her is a big baby. A 2.5 baby for this woman is a severe IUDR. And that is the problem. That is the baby's own gross potential. And I like this slide as well. We'll show you these two babies here and here. The same baby, same weight. This baby here is a very healthy baby, growing very happily. This baby is in deep trouble. This baby can be stillborn at any time. This baby will have no problem at all. And yet, the weight is the same. So it's not about the weight at all. It's about its own gross potential. Now, we're going to talk about something which is causing me a lot of pain all the time, fetal biometry. And I'm so happy that we're talking about this in front of you, really the nurses, those who scan, sonographers, because unless you know the exact age of the baby, forget about IUDR. We have no chance whatsoever to diagnose and manage IUDR if you don't know the age correctly. No chance. Absolutely no chance. In the first trimester, we have the CRL. In the second trimester, we have something which you know better than me. Head circumference, doing circumference on female legs. And the question will be, how do we measure these babies? So before we know that, we have to know the exact age of the pregnancy. And I'm going to spend some time here, and I go slowly for those who are just doing scanning, just to study the scan. We calculate the date of delivery by this old man theory, Nagelni's rules. We all know about it. You add 9 or subtract 3, and you get the new dates. But this man, when he put his rules, he assumed that all women have regular period of 28 days or 5 days. And surprise, surprise, half of the women in this room have no regular period. And that is the reason. There is so many reasons, as you can see, which can tell you that there is these rules cannot be applied. Or the rules which we learn every day is not true because of these reasons. Bleeding in early pregnancy, being on the combined pill, unsure of her dates, many, many reasons. And that's why I want you to wake up with me for 5 minutes, be awake, and then when I finish 5 minutes, I'll tell you to go back to sleep again. So please wake up for 5 minutes. The question is, how would you sort out discrepancy between the mother fetal age based on the history and ultrasound? And there is a very simple rule. If you see the woman in the first trimester, you do your scan as Karim and Ozrik and Nassim was saying, very nice ultrasound, you do your CRL properly. If the dates of the ultrasound agree with her dates, well and good. The discrepancy is more than 5 days, ignore her dates and go by ultrasound, and please document it. When I get an IUDR baby, trust me, I spend most of the time not doing scan, looking at her nose to see a small piece of payment which I scan at 6 weeks or at 7 weeks, which I scan somewhere. I look at in her payment, I spend half an hour trying to find the scan done by you and early pregnancy, because the scan done by you in early pregnancy is much better than my scan in late pregnancy after 30 years of experience. But this is very critical that is the rule of 5. In second trimester, if she came in second trimester, is the rule of 7. We do a BBD, head circumference, abdominal circumference, female length, whatever. If the dates of the pregnancy and her ultrasound dates are correct, fine. If the difference is more than 7 days, forget about her dates and take ultrasound date, write it down in the red pen, tell the patient that you're doing it so and so, and that will never change. That will never change. When the patient came to the clinic with date every visit, that is very worrying for me. So I'm sure you will not make that mistake. So again, the question is why talk about IUGR? Because we worry about stillbirths and hypoxemia. In spite of all the development in fetal medicine, all the development we're having, the management of IUGR until this moment, the management of IUGR is simple. Timing of delivery. We cannot do anything else. All what you are doing after all these years of experience and working hard and research, travel study, all what you are doing is we are offering to deliver the baby at the right time. And that is the balance between getting the baby too soon and suffering from preterm prematurity, or leaving the baby to stay inside for so long and suffering from IUNP. That is the balance. Most of the time, unfortunately, we will choose this one. Get the baby out and give it to somebody else. Is that the best interest of the baby? The answer is definitely no. Because as you can see from the slide here, the more the baby is staying in utero, the better is the condition of the baby. And such a baby like this, with severely IUGR, with hypoglycemia, hyponatremia, hypodrogemia, hypo, that will not survive if you get them too early. Even if they survive and they come out and they live, there's a high chance of getting problem like cerebral palsy. And if you can see in the slide I written here, that the chance of cerebral palsy is much more higher in IUGR babies compared to normal babies. So there is a need for us to make a diagnosis and to try to maintain pregnancy as long as possible. Now we have a problem, and we have some good news. The problem is half of the IUGR babies are not diagnosed in pregnancy. In a way, that is good, because these IUGR who are missed are normally minor or not severe IUGR. Luckily, they are not diagnosed, so they are not intervention. But this is true. The question is, why do we have this very low detection rate? It's simple, because we rely to diagnose IUGR, we rely on what? Abdominal palpation and subsequent height measurement. Both methods, to say the least, are very inaccurate. If you palpate the tummy of the abdomen, you get the feeling that this baby is 2.3, 3.2, so 4.2, so all very, very arbitrary. All the research have shown that we are not good. Measurement with the tape is slightly better, but not accurate. So the message from here is probably you have to spend more time trying to make a diagnosis by measuring the baby's weight rather than palpation or specific fundal height. So the question is, you diagnose an IUGR, what do you do? When you diagnose an IUGR baby, the next question is, decide the time of delivery of this baby, and the theory or the philosophy is keep the baby in utero as long as possible. How do we do that? By antepartum monitoring. Antepartum monitoring. The most important thing we monitor is the fluid, amniotic fluid. Amniotic fluid is one of the very good indication that the baby is okay. You can see this here. There is a very good board of Riker, and I just take the opportunity to tell you, please don't use AFI. Just use the deepest vertical measurement. That is the internationally used measurement. That is all in the papers. The AFI is very confusing, and it's not as good as the deep vertical pool. So deep vertical pool will be more than enough. But do it properly. Choose a place where there is no baby, where there is no cord. And I like this old video. I love this video. It's a very old video. Because it makes the point. That's what happened in utero. The baby reduced urine.
If you think how study was conducted, in the shorter variability, there's a loss of revenue criteria. How do we extrapolate that to our normal practice? Because we don't use it for CTG in our daily lives.
And for me, the simplest way is to go by Douglas. And as long as Douglas are normal, I'm quite happy. Because doctor will give you a sort of assurance for at least 72 hours. If the baby needs doctors, I go do it every day. One of the things about private practice, one of the good things about private practice, you can do the pain as frequent as you want. And that probably data come from private are slightly different. Because these are pain you can see every day. You know them. If you work in a bed like HMC, which is a big hospital, and they're doing a very good job, it's difficult to be a specific doctor to specific patient. That's why we're in this position.
Thank you very much for your nice.
It is very good enough to say, umbilical double is normal. That's more than enough. But if the baby is IUDR baby, and it will come back to you again, you want to do the measurement, so you can compare.
Actually, the figures are reported by ultrasound itself.
Yeah.
So we will just forget it and look with a visual to say whether it is normal or not.
Exactly.
And it was a reading will be in the report.
Exactly. Unless there is a problem, and then you want to specifically put that number and repeat it 20 times. If there is a problem, I advise you to repeat the measurement and do the measurement around the blood as well. So you have a baseline to compare in 2 days time. But if the baby is growing normal and the umbilical double is normal, that's enough. Umbilical double is normal, it's more than enough. Yeah.
We don't do any termination for any pregnancy. All what we do is we refer our patients, whatever abnormality they have, to women's hospital, and there is committee there, and those people they decide whether this patient is eligible to be terminated or not. Now, there they follow the Sharia mentioned by Dr. Fawad, but all what we do practically is we refer our patients. But I'm afraid that they will close our clinic tomorrow.
Very basic, gestational age and cerebellum measurement. Like a woman coming in without any antenatal checkup, no certain dates, nothing, she had been hopping from one place to another place. So the role of cerebellum done in the measurement.
The question is about role of cerebellum measurement to determine
So thank you very much once again to all our speakers for today. So before we formally
it is very good enough to say umbilical double is normal. That's more than enough. But if the baby is IUDR baby and it will come back to you again, you want to do the measurement so you can compare.
Actually, the figures are reported by ultrasound itself.
Yeah.
So we will just forget it and look with a visual to say whether it is normal or not.
Exactly.
And it was a reading will be in the report.
Exactly. Unless there is a problem, and then you want to specifically put that number and repeat it 20 times. If there is a problem, I advise you to repeat the measurement and do the measurement around the blood as well. So you have a baseline to compare in 2 days time. But if the baby is growing normal and the umbilical double is normal, that's enough. Umbilical double is normal, it's more than enough. Yeah.
for all our delegates, so please do find time to answer this. And once you're finished, please do present this again to our staff. Thank you. So this is a part of the protocol given by the Qatar Council for Healthcare Practitioners. Okay, ladies and gentlemen, at this point, we will be awarding a small token of memento. Laboratory Administrator for Microhealth Laboratories Qatar, also a member. Of course, we also have Also, we have Dr. Osric Nafti. And of course, today's symposium will not be possible if our professor